Good evening, everyone. So it looks like we are right at 5:30 Pacific time, so we will go ahead and get started. So first off, I would like to thank you all so much for joining us to hear the latest science update on dental caries in Canberra. We do have some really exciting stuff for you tonight, but before we jump in, just a few housekeeping items. You are all muted on the call, so we can't hear verbally any comments or questions. If you do have any questions during the presentation, please type them into the Q&A box on the right-hand side of your screen, and you may need to escape out of full screen mode to see that box. And then at the end of the presentation, we will have about 15 minutes to answer a few questions. If we don't get to them all, we will be replying to those throughout the remainder of the week, and so we will get back to you on that. And then last but not least, the webinar has been recorded. Or will be recorded, and you will all be sent a follow-up email with the link, so you can view it at any time, or you can share it with colleagues if you would like as well. So with that, I would like to go ahead and introduce Dr. Kim Kutsch, our presenter tonight. He is the CEO and founder of Oral Biotech in the Carie-free system. And Dr. Kutsch has been successfully practicing dentistry for over 30 years and still practices 3 days a week here in Albany, Oregon. And he has an incredible passion for what he does and his vision to create effective Canberra protocols, which continues to drive him in his research to improve caries diagnosis and treatment. So Dr. Kutsch, I will let you go ahead and take it from here.
All right. Well, thank you, Kendall, and thank everybody for being online with us tonight. This is one of my favorite topics. Every year I kind of try to stay on top of the caries research. It goes on in our journals throughout the world, and I put together a program for several different organizations where I kind of update the research in the dental caries model. So tonight I just want to pull out some studies that I think I can highlight from the previous 12 months. In fact, some of the studies are actually from this year that I think are significant and that certainly bear our attention and kind of help us complete the picture of, what dental caries is as a disease and how that whole model is. One thing that I would recommend to you, if you haven't read this book, this is one of the best business books that I have read. It's by Simon Sinek. He did the TED Talk, I think, 3 years ago on the topic of start with why. And it really, the point that he makes in his book and in his TED Talk is that most businesses focus on what they do or how they do it, but very few businesses focus on why they exist. Why do they do that? And so, the big question is why? Why do we get out of bed Monday morning and go to our practices? Why does it matter? Why do we do what we do? And so in his TED Talk, he kind of describes those golden circles, and the really uber successful companies are the ones that are real clear about their vision of why they exist. So, just to start with why tonight, why I'm here and why I do what I do is that we have a pandemic of dental caries, throughout the globe. It's the #1 disease in all age brackets of people here in the United States, and that's not okay with me. I'm not okay with that. I, went to dental school. I wanted to help people, and was told, 34 years ago when I graduated that literally they wouldn't need dentists 35 years in the future because of fluoride. And here we are, in 2013 with higher decay rates than I believe I've ever seen in my career, and they're getting worse. And so it's really, this is a huge challenge for us. It's not something we're going to drill and fill our way out of. That doesn't work in terms of treating this disease. That's the whole basis for, Canberra and caries risk assessment, that whole model for therapy. And I believe it's our problem to solve. I think that, our fellow citizens are looking to us as the experts, and they really expect us to be able to help them with this problem. So, what's causing this pandemic? Well, for the last couple of years, I've been teaching this concept of the usual suspects. If you look at all of the risk factors associated with dental caries, it gets quite confusing and overwhelming. But if you break it down, what I see in my practice is a recurring theme of about 4 or 5 patterns over and over and over again. And if you can kind of train yourself on that pattern recognition, then it's a pretty simple thing that, oh yeah, here's a person who's xerostomach because of medications that they're taking. That's the main risk factor that they have, and therefore that means I'm going to use X kind of therapy for that person. And so once you kind of get those things into your thought process, the whole camera model becomes easier and easier. So when I was, in dental school, we were taught the disease model. The usual suspects were Mutant, Streptococcus, and lactobacillus. And while I think that those are factors in this disease, certainly this the bacteria involved and the other suspects now it's a lot broader, and we know a lot more about it. In fact, now I would actually tell you that my suspects would include bacteria, the biofilm. Typically, those patients that are high risk for dental caries either have too much biofilm, they have too much bacterial load, or they have too highly of an active biofilm. And we're going to talk a little bit about that and how the research relates to it tonight. The other pattern that I see typically is it's a dietary issue, and either they're consuming too much sugar or they're eating too frequently. And certainly saliva is one of our suspects. And typically what I see there, and I know that you all struggle with, is this xerostomia issue, particularly in our senior patients, medication-induced xerostomia. Or another issue could be they just have poor buffering capacity of their saliva. That's not something that we can test for and measure very readily in our clinical practice, but that certainly could be an issue for somebody. This year I've added a fourth suspect, and that's genetics. And I'm going to go through some of the scientific studies that have been published in the last 12 months and really give you a feel for how that field is really expanding, and so much so that I would say the greatest weight of all of the new scientific evidence that I've read in the last 12 months, most of it's been in the area of, what are the hereditary factors for dental caries. So that area is really growing. But at the end of the day, of course, we know that it's our old friend Kaiser Sose, and it's really pH is the basis of this disease. One of the first studies I want to start you off with tonight is really on looking at, in the past, that for people that have been, have attended these webinars with me, one of the things that I've presented in the last couple of years is the fact that we as clinicians tend to look at our evidence base and interpret our scientific studies differently than our educational branch or, say, our research branch of the profession do. And they tend to look at cross-sectional studies of populations, and we tend to look at longitudinally at individuals in our practice. So with that in mind, we start looking at some of the research that's come out, and in this particular study I thought it was very interesting. How many people would put sealants on those mandibular premolars, and certainly we've got some pits even on the canines. And so we start looking at that, and in this study they looked at 6,900 patients, 50,000 unrestored surfaces, and found basically that 34% of all patients and 11% of all tooth surfaces had questionable occlusal lesions going on in them. It was questionable. So you and I look at that patient, and we have to make a decision. You do this every day, and so do I. Do I put a sealant in this occlusal fissure? Certainly the scientific evidence indicates that if we've got a non-cavitated carious lesion, that certainly that supports us putting a pit and fissure sealant in there. But you and I struggle with, is that appropriate or not? And we're not following the recommendations, by survey. Last year, we're not following the recommendations of the ADA Council on Scientific Affairs as clinicians, and people are scratching their heads saying, well, why not? Well, we look at patients like this, and, well, it looks questionable. I'm not sure whether to seal that or not. And one of the things that we do as clinicians is we make a mental decision to seal or not seal, or to restore, or do nothing based on their risk. So I haven't showed you the whole picture on this patient. I asked you the question, but how many people, when I show you the rest of the story here, feel as comfortable now with those occlusal fissures as you did just a little bit ago? So, we start to make decisions based on our risk, and I think that's appropriate, and that's based on an individual patient. In this study, they did a survey, and this was based on the practice-based research network. This was done in Japan, and they surveyed 189 dentists, and they were trying to figure out at what point in time by survey do dentists start to restore interproximal radiographic radiolucencies. At what point in time did they determine that needs to be restored? Now, if you looked at these lesions here on 29 and 30, back when I was in dental school, when I was getting ready to take the board exam, you looked for a lesion like this for the board exam. It was just kind of an E1, E2, not quite yet a D1 lesion, so it was that ideal classic board lesion. And we now know that 85% of these lesions are not cavitated, so they should not be restored. We should be starting by doing remineralization and attempting that with these lesions. Yet you and I look at that, and we have to make these decisions every day, all day long. And so when they were asking these dentists in Japan at what point in time, what they found was that where they made their decision to restore or not restore wasn't a finite black and white line here on is it at the DEJ or is it a D1 or D2 lesion, but they made that assumption, or they made that decision based again on the patient's risk. So if I show you the rest of this X-ray, those lesions on 30, 29, those radiolucencies on 29 and 30, they don't look that significant. It's not something that we would jump to restore, but when you start looking at all of the other lesions in this patient's mouth, suddenly I'm not just as comfortable with those two lesions as I was before I saw the rest of the picture. So really, that whole risk for dental caries, we're doing this whether you're doing it intentionally and thoughtfully and documenting it, or whether you're making a mental note and you're doing it, kind of subconsciously. We all do this. We all do a risk assessment in our head, and that's what we're using to make decisions on. And I saw this patient's been in my practice from the time she was born, and she spent the last 2 years in Italy abroad studying. And, the question I've got for you is how many people would restore, or how many people would seal this second molar? Yeah, it looks a little suspicious there. We look at the radiograph before she took off to go to study abroad, and it's like, okay, so there's, I don't really see too much going on. That looks like something safe to restore. And she comes home, and now she's home just this last month and getting ready to head, I think, to Asia or someplace to do some study abroad. And she comes in with a toothache, and I look at this lesion, and this happened in the span of 2 years. And this is why we don't just routinely seal teeth, and we don't, because this is a longitudinal issue here of 2 years for an individual. So it's great to talk about cross-sectional studies of big populations, but this is one of the ones that didn't work. But for that patient, it became, 100% issue, and actually we ended up extracting that tooth. So, we look at this, and we have to make these kind of decisions every day. So when we talk about what is dental caries, we have our biofilm disease model currently. We know that there's multiple pathogens involved. We know that there are systemic effects, and now we know there's growing evidence on our hereditary components. I'm including a couple of studies here that are 2 or 3 years old, only from the standpoint that I think they're significant and we need to continue to be reminded of them. This one from David Baton, and he happens to be the editor of the Caries Research Journal. This was from 2010 in JDR, and they did a study on older adults, and the only thing that correlated with their caries rate and their age was the levels of Bifidobacteria in their mouth. Now, so we can add that as a cariogenic agent. By the way, they looked for Mutant, Streptococcus, and lactobacillus in this study as well, and the only thing that was significant was Bifidobacteria. Now, the reason that I like to highlight Bifidobacteria here and tell you that this is a concern, Bifidobacteria is being kicked around as a probiotic to treat patients that have dental caries. So I'm thinking that we have to be a little careful about, what bacteria we're going to be using and replacing. Now, Ann Tanner's group at the Forsyth Institute at Harvard, this study, she had a great year in 2011, identified actually 2 new cariogenic pathogens in children, and this was in February, and she first identified Scardovia wigsii. And so they looked at this for the children that had severe early childhood caries and had the presence of strep mutans, and even in the children that had no strep mutans, and by the way, about 40% of these kids now have no mutant streptococci whatsoever. And so, but what the common factor that they all had was very high levels of Scardovia wigsii. So now we've got a new cariogenic bacteria, certainly that we recognize in children. And in November of 2011, her team again identified yet another bacteria for children that had advanced lesions, advanced severe early childhood caries, and found that those patients, the significant bacteria associated with that disease is Slackia exigua. And what I thought was really interesting in this study was that I've been promoting, well, you just saw me talk about the usual suspects, that people tend to break down into they have a bacterial issue, or they have a dietary issue, or they have a salivary issue, and now we're going to talk about, potentially they have a genetic issue going on. But So Anne was the first person that I've seen, besides myself, that's starting to identify. She said that her data broke into two groups in these children. And think about children. Typically, saliva is not very often an issue for children. They have lots of saliva, unless they're taking medications. They have asthma or ADHD or whatever. But they break into two groups in her data. They either had a problem with diet or they had a problem with bacteria. So we added Slackie exigua. This study was just out in the Caries Research Journal in January. This is Diana Wolf from Germany and her team. And they took 26 high caries risk adults and compared them to 28 caries-free adults. They did a bacterial scan, a checkerboard basically of 43 different bacterial species, and added a new one yet again. The only bacteria that was strongly associated with dental caries, the difference was Propionibacteria acidifaciens. So we've added just 2 months ago, added yet again a new bacterial pathogen. So we need to continue to be, I think, cognizant of the fact that this is a biofilm disease. I know that model of mutant streptococci and lactobacillus has been pounded into our brains, and if you've been at this as long as I have, those are paradigms that are kind of hard to let go of. But we need to be cognizant of the fact that we're continuing to discover more and more new bacterial species all the time. Now, one of the things that we know about dental caries is that it does also have potential systemic effects, and these are some studies that date back. Nakanov's group in Tokyo, they did a series of studies looking at arterial and cardiac plaque specimens from patients that were in the operating room during grafting or open heart or valve heart surgeries. And what they found was that they were cognizant or aware of all the research that we've got demonstrating live periodontal pathogens in these plaque samples. They asked a simple question: gee, it's interesting that periodontal pathogens are there. I wonder what other oral bacteria are also present. And what they found was that the number one bacteria, when it was found in the mouth, it was found 78% of the time in these bacterial, or in these coronary plaque specimens, turned out to be our old friend Strep mutans. In fact, their conclusion was that Strep mutans is the etiologic agent for most bacterial endocarditis. So it's we know that there are systemic effects, and by comparison, in the studies, the presence of the periodontal pathogens were negligible. So I'm not telling you that that there isn't peripheral vascular disease associated with periodontal pathogens, but I would tell you that it may be more than just those bugs, and as we go forward, we may see more and more from the cariogenic bacteria as well. One of the things that we do know, and this was published in 2011, is that Strep mutans actually have a gene that allows them to invade endothelial cells. So the question becomes, how do they set up their biofilm there? How do they create this issue? Well, we know that Strep mutans actually, with this particular gene, can directly invade the endothelial cell. So we know the mechanism for that. So it's one reason that we probably have that problem. So this was published in June this last year. It was a study that looked at clinical attachment loss of more than 4 millimeters, and then comparing that to peripheral arterial disease. They found a high association also with the creative C-reactive protein. The other thing that they looked at in the study and they analyzed was the DMFT score. And so what they found was that patients that had high clinical attachment loss had an increased peripheral arterial disease, peripheral vascular disease, if you would. Patients that had a high C-reactive protein score also had high association to peripheral vascular disease. And patients that had a high DMFT score also had a high index. But the point that I would like to make is that probably, so it's easy to say, oh, so they had a high caries rate. Those patients also had high levels, or it correlated to peripheral vascular disease, and it does not. Most of the studies that look specifically at dental caries and those pathogens, or caries scores, or risk for caries and peripheral vascular disease or coronary artery disease, don't find a really strong correlation. There's sometimes you find some, but it's not a strong group of studies like we have. It's not the evidence base like we have with the periodontal pathogens or periodontal disease or periodontal symptoms. So the one thing that I think that happened here is that they had missing teeth. I think that the missing component, the missing teeth part of the DMFT score was what was probably driving that association, and it didn't look at why the teeth were missing. Were they missing because of dental caries, or were they missing because of periodontal disease? And I'm going to assume that for this study, to see consistency in this study with other studies that I've seen, I'm going to assume those teeth were probably missing because of periodontal disease, and that kind of throws our data off here a little bit. So you have to be careful when you look at some of this data, and you just read the study, read the conclusion. It's like, oh, so, you know, high DMFT scores, you know, were strongly associated with peripheral vascular disease, so dental caries, therefore, is associated with peripheral vascular disease. Well, if the reason the teeth were missing was periodontal disease, then it isn't really truly about dental caries. So I just want to throw that out. And then we've had a number of studies in the last 3 or 4 years, and this came from the University of Pennsylvania, or was it at Pittsburgh? And they looked at 300 individuals randomly, and they tested them. There are 3 different polymorphisms for beta defensin 1, which is a salivary bacterial enzyme. So it's a defensive mechanism in the saliva, and what they found was that the people who had the G20A polymorphism had 5 times the decay rate, the DMFT scores, of everybody else in the study. So when you get to an odds ratio of 5, you've got a pretty strong association. So we know that, you know, these are some of the first genetic studies that were reported. The TAS2R38 gene is associated with a bitter taste, the taste buds, and so we call these kids hypertasters or super tasters. We also know the TAS1R2 gene for sweet preferences in the taste buds. Both of those are associated with an increased risk of dental caries. So first we had a bacterial or a bacteriolytic enzyme in the saliva. Now we're talking about taste buds. This was in 2010 as well. Now this is from 2012, and propylthiouracil, PROP, is one of the bitter factors that these children with the TAS2R38 gene are very sensitive to, and those are found, propylthiouracil is found in a lot of the green vegetables. It's found in soy products as well. And so these kids avoid a lot of the healthy vegetables because they're really sensitized to these agents. And it's actually in this study, you can test for that with filter paper to see whether or not they are sensitized to the taste. And that was actually correlated to the bitter taste and the sensitivity, and that's going to correlate then to their caries risk. So we're starting to look at how can we measure, how can we test for that as well. This study I thought was very interesting. Now we're looking at matrix metalloproteinases in the dentin, and found that people that had a mutant gene for MMP13 had a significantly decreased risk for dental caries. We know that the MMPs are responsible for the breakdown of the dentin and the protein component in the dentin. And so when I think we've had that conversation recently about the systemic theory of dental caries, it requires the MMPs to break down the dentin. So is this an internal versus an external association? And that's a great conversation. It's a good thing to talk about. But the reality is, you know, we're starting to look at now some of these MMPs, and there is an association, a hereditary association for different polymorphisms of these genes, and they affect the decay rate as well. And this was in Caries Research Journal this last year. Another study that was in Caries Research Journal last year was on the human leukocyte antigen DQ2, and people who had this, or children that had this allele, were less likely to have dental caries than their counterparts who were negative for this allele. And so now we're adding white blood cells, matrix metalloproteinases, salivary enzymes, taste buds. You're starting to see the expansion of the different types of genetic factors that can contribute to dental caries. This study is Schaefer and Feingold, and I thought this was a very interesting study. This is just out in January of this year in JDR, and They looked at 920 adults from age 18 to 75. They looked at 518,000 different genetic variations or gene sites, 518,000. And what they came up with 11 strong associations between different genetic variations and dental caries. Now, the strongest associations of these was lysyl-2, which is, again, a bacteriolytic enzyme found in the saliva. And what was interesting is their data broke down into 5 distinct geographic patterns of decay within the mouth. And we're going to talk about that in just a little bit. But in the study that I found was interesting was they said that this lysyl-2 genetic variation was associated with a geographic pattern of dental caries that affected only the mandibular incisors. Now, I want you to think for just a second and, think about your patients in your practice. How many times have you ever seen a patient that only had caries lesions on their mandibular incisor teeth? And I mean, I'm reading the study and I'm scratching my head thinking, I'm not really sure I've ever seen that. Typically, if those are the last men standing. That's the final stage of the disease. The last 6 teeth in the mouth are the mandibular incisors. And if you've only got 2 teeth left, they're the mandibular canines. That's where most of the saliva is present in the mouth. That's where you have most of the protection of any teeth geographically in the mouth. And so for those to be the only teeth affected, I thought, well, that's really interesting. I'm not sure I've ever seen that. And then 2 weeks after I read the paper in January, this 14-year-old patient was referred to me by a local pediatric dentist, and they have repeatedly refilled these lesions on the mandibular incisors. It's the only cavity she's ever had in her life. And her mother exhibits the same pattern of decay in her mouth as well. So I thought, scientific study of 2 here in my own personal practice, but suddenly I could explain to this patient what I think was causing this pattern of decay that they had. So you still have to go and try and figure out how to account for it or how to balance their health, but at least I had a reference, and when I looked at the study, I could identify a patient that fit the study. They also published a second paper in January this year in the Journal of Dental Research, and they just looked at cluster-based caries outcomes and just determined that some of them are inheritable, and then there are other common risk factors that are environmental, such as age, educational attainment, toothbrushing habits, etc. So some of the risk factors for dental caries, as they look at a large cohort, some of them tended to appear to be inherited, and some of them tend to be environmental or behavioral in nature. Now, Takahashi and Neved, back in March of 2011, over the last 3 or 4 years, they published 3 or 4 papers that I've found to be extremely significant. They've taken Philip Marsh's ecological plaque hypothesis theory and they extended it. And in this paper, I want to bring this up for just a second and kind of refresh your memory. This was really, I thought, a landmark paper in my mind. They talked about dental caries occurring in 3 stages, the first of which you've got this dynamic stability stage with the Stefan curve where, the patient eats or drinks something, the pH drops in their mouth. 20, 30 minutes later, the pH recovers, and in that process, we lose some mineral out of the enamel, and, 30 minutes later, it goes back into the enamel, and so you've got this dynamic stability stage going on. And then as it starts to shift because of a risk factor, the first thing you start to see is that you start to see an acidogenic phase, and that the biofilm becomes more acidogenic. And as that continues, what happens is it becomes acid uric. And the only bacteria really that are surviving and found in the biofilm are then strongly acid uric bacteria. So their point was that dental caries is driven by environmental acidification of the biofilm. And so that's kind of an extension of Philip Marsh's early hypothesis, but I think it was 2 years ago gave us a really strong kind of a well-focused kind of big picture, if you would, of what dental caries looks like. Well, Lizzie Buchan is I think has a degree like in neurosciences, but she writes for Nature magazine, or that Nature journal, I should say. It's a very well peer-reviewed scientific journal. Anyway, she wrote a paper 3 years ago talking about biofilm and the new germ theory, and her point in this biofilm research is that biofilms behave as a singular organism. And so for us to talk about looking at worrying about which bacteria is present and you know, what's there, the proposal that she made, and it was kind of a novel idea 3 years ago, was that we should stop worrying about which bacteria are present because it really doesn't matter. This biofilm itself behaves as a single organism. And so what we really need to look at is all the genes that are present. Like, because now with our metagenomic studies, we can break it down and look at what genes are present in the biofilm. It doesn't matter which bacteria cell wall and what name we've given it that's holding those genes. Those genes are going to be expressed. Those are, if they are expressed, they're important genes. And the gene itself is more important than the name we've given to the bacteria that's present. And they share genes. They share DNA, and that bacteria do that. So we really need to look at a biofilm as a superorganism rather than get caught up into the naming of and identifying bacteria like I just shared with you, as we have identified all of these new cariogenic pathogens. So she proposed this a couple years ago, and then in the Caries Research Journal, this is just out in March of this year, Takahashi and Nevad again, I think, have again expanded our thought process or understanding of the dental caries disease model. And in here, they took Lizzie Buchan's thought process and said, well, let's apply that to the dental caries biofilm. And in fact, we can look at the entire genome. We can take a biofilm and we can look and we can do a metagenomic analysis, and we can identify all of the genes that are present in the biofilm. And then we can look at the ones that are actually active or transcriptive, and those are producing proteins. And so we can do a metaproteomic study. We can look at all the proteins that are being produced. Those proteins basically are metabolic enzymes that create an activity within the biofilm. We can do a metabolomic or metabolic study of the biofilm and look for its output. And in the case of dental caries, the output would be acid production, essentially, and then that creates lesions in the mouth. And each step there, that process, creates the feedback within the biofilm for selecting which bacteria are there, for those bacteria adapting and behaving differently, for those bacteria then producing different proteins which are going to modify the output for this biofilm to create some stability for itself and sustain itself. So their point is that we need to stop worrying about the composition of the biofilm. We need to stop being so focused on which bacteria are present, and we need to start thinking about what does the output of the biofilm look like. Well, so if we take one of the figures from this paper, instead of being focused on doing the 16S DNA sequencing and looking and trying to identify new bacterial species and figure out which one are causing this disease, we need to look at the biofilm itself that's causing the disease, and we need to look at the output of the biofilm. And we measure the activity of the biofilm. And one of the ways that, interestingly enough for me, that we've been measuring activity for the biofilm is with ATP. And we've been doing that for about 9-10 years now. And that tends to be a very predictive, easy biometric for us to use. Anyway, so I just wanted to share, if you read one paper, let me back up here for a second. If you want to read one paper this year and really spend some time understanding the dental caries and where the research is headed in dental caries, this is in the current issue of the Caries Research Journal. I had to read this paper 3 times before I really got my brain around it, but I would tell you that this would be the paper to read because I think it's very impactful. Moving on then, looking at other factors in dental caries for this last year, Hanig and Hanig have done a lot of research on nanoparticles of hydroxyapatite. I think that certainly there's been a lot of research on nanoparticles of hydroxyapatite. I think that remineralization is going to be moving in that direction. Certainly that's where we're at, where I'm at, but I think you're going to see that in time as well. So in this study, one of the things that they did is they looked at bacterial adhesion and recovery of a biofilm and adhesion on a surface based on different factors like chlorhexidine they used as a control in the study. They treated the enamel surface with chlorhexidine, and they looked for regrowth of the biofilm as a result in 6 hours and 12 hours later. And they looked for antimicrobial effects on strep mutans. And so then they combined hydroxyapatite nanoparticles with xylitol and sorbitol and saline and just the liquid phase, and then they looked at hydroxyapatite nanoparticles all by themselves, which, by the way, those nanoparticles of hydroxyapatite are found in the saliva. That's the form of calcium phosphate found in the saliva. It's basically a 20 nanometer particle of carbonated hydroxyapatite, which is the basic building block or brick of enamel. So what they found was that the hydroxyapatite and xylitol mixed together substantially affected the regrowth. Now, if you look at these photographs, again from the paper, on the left you see the control. This is what it looked like prior to the chlorhexidine, and then this is what it looked like 6 hours later. The next column over on the bottom, you see hydroxyapatite and xylitol together in solution. Here's 6 hours later, and here's 12 hours later in terms of bacterial adhesion and regrowth. The next column in the center is xylitol by itself, and you can see that all of these have reduced the regrowth or the bacterial adhesion. The next column over is the hydroxyapatite nanoparticles just by themselves in a saline solution, and they actually interfere or reduce the bacterial adhesion. The next column to the right is chlorhexidine, and actually in the study did as good a job by themselves as chlorhexidine did. So I think this is a very interesting process to start thinking about the fact that, you know, when we look at how nature handles this, how does nature keep us healthy? How does nature deal with creating some dynamic stability in the mouth or creating homeostasis? You know, the saliva has hydroxyapatite nanoparticles, and they have that effect on the adhesion. Another study that Hanning and Hanning did in this last year, this was in September in Advanced Dental Research Journal, they looked at the analysis of in vitro data using, again, nanoparticles hydroxyapatite and looking at its effect on remineralization on artificially created lesions. And what they found was that it appears to help reverse the lesion in the outer part, but not deeper into the lesion. And so that's really consistent. I know one of the things that I hear kind of repeatedly out there in the profession being bannered around is how you can remineralize teeth from the inside, remineralize lesions from the inside out. I'd love to see the theory and the research that demonstrates that, because all of the research I read indicates that that enamel is basically a crystal, and it remineralizes by oriented attachment just like all other crystals in nature, and that occurs from the outside in. And enamel, most of the studies demonstrate remineralization from the surface of about 100 to, at best, maybe 200 microns deep. So this is real consistent with all the rest of the research that I've seen in other attempts to remineralize. This is actually a paper that I and John Kois wrote, and Yada and Graham Milicic, and this was published actually in this month's issue of Compendium. So if you're interested more in remineralization, we went back and actually looked at remineralization dynamics. We looked at the physics of how crystals in nature remineralize. We looked at how enamel remineralizes, and then we kind of tested that with some nanoparticles of hydroxyapatite to see if it would adhere to and appear on the surface. And we created, again, some artificial lesions. And while we didn't find huge significance in the study, we did demonstrate that the nanoparticles of hydroxyapatite do adhere to the surface of the enamel. So we thought that was quite interesting, and it's consistent with other research that's been done with nanoparticles of hydroxyapatite. So if you want to understand remineralization chemistry, I would encourage you to look at that paper. This paper was published in JADA in January, and I know that I discussed it in a couple of the lectures I've given this year. I'm not sure we've covered it in a webinar yet this year, but I got more emails and more requests for opinions about this particular study than probably any study that I've seen in the last 3 or 4 years. And I got to tell you, Bader and Sugars and Ballmer did a great job. This is a very well done study, and I think it really highlights for me some of the beliefs that I have about dental caries. Now, you have to be careful how you interpret data. So what they took in this study, I think they ended up with 691 adults that were all high risk for dental caries. I think they had something like from 1 to 7 active carious lesions, and they followed them. It was a multi-site study. There were 3 sites. They followed these patients for 33 months. They gave them 5 basically xylitol mints per day. and then looked at the outcome. How did that affect the caries rate? And there was no significant difference in the outcome between the controls who did nothing versus the people that used xylitol. So the conclusion of the study was that there was no clinical significant reduction by using 5 xylitol mints every day. Well, I have to tell you that, so a lot of people jumped up and said, see, xylitol doesn't do anything for dental caries. Xylitol isn't any good. Xylitol doesn't make a difference. I've heard all of these different conclusions, how people interpreted the study. And what I would tell you, this is how I interpret the study. This proves one more time that, for me, that dental caries is a multifactorial disease. It's not going to be answered with a silver bullet. There is no silver bullet. There isn't going to be one. This is a multifactorial complex biofilm disease that has numerous risk factors. And so when you take a study of 691 adults, and we don't know what the risk factors were. So xylitol may actually have been effective for a small group of these individuals, but for the bulk of them, like, for example, if you had the patient, the cause was xerostomia, giving them 5 xylitol mints a day isn't going to be enough to overcome the medication-induced xerostomia. Now, maybe in the form of gum, because that stimulates more salivary flow from the chewing of the gum, maybe that would be enough to make a difference. But take a person who has a dietary problem, and just think for yourself for a second. The problem is that they're drinking 12 cans of Mountain Dew a day. Giving somebody a 5 xylitol mints is not going to overcome the dietary issue that they've got. Or maybe they don't brush their teeth, and maybe they've got too much bacterial load. So all of these 691 patients had different risk factors going in and had a different pattern of disease. And so just taking one protective factor and using it for everybody in a population study, that's not how we're going to be effective at treating this disease. We need to make an individual diagnosis and risk factor. We need to look at that pattern of disease for those patients individually, and then we need to come up with an individualized treatment plan. Now, in my mind, we would cluster fluoride and xylitol and pH and some of those strategies all together just to make it simpler in the process, but you're not going to just pick one thing and have it go across the board and be totally effective for all patients. That's not going to happen. So I think the study is very well done. I agree with their conclusions. What I would tell you is how I interpret the conclusion, however, is not that xylitol is bad. That xylitol by itself, in the form of a mint, is obviously, based on this study, not sufficient to solve the dental caries issues of every adult. So I hope I clarified that for everybody here a little bit. It's a challenge for us when we look at these studies. I mean, it was very well done study, and I have a huge amount of respect for those researchers. So, and I believe their results. But my conclusion is that I wouldn't have expected 5 xylitol mints to have had any significant effect by themselves on these patients. So I think, we need to be careful how we look at these studies and we look at the conclusions or make assumptions based on them. Certainly, I think that there was the New York Times, I think, that highlighted, aha, xylitol doesn't work. I think they had this big scandalous expose, on based on this study, and it's like, they're always looking to sensationalize stuff, I think, in the news. But anyway, that, be it as it may, let's move on. Svante Twetman is one of my favorite researchers in probiotics, and the thing I love about Svante is he is not afraid to publish negative results. And again, I mean, we just looked at a negative result on xylitol. In this case, they used Lactobacillus reuteri, and they took 62 young adults who had moderate and high levels of mutant streptococci. They were high risk for dental caries. They disinfected their mouths with chlorhexidine. Then they did a baseline look at mutant streptococci. They tested them again at 1 week, 6 weeks, and 12 weeks. And then in the meantime, the test group got 2 tablets a day of this lactobacillus as a probiotic. And then they wanted to look at what happened then to the mutant streptococci. Did it replace it in the biofilm? Did it suppress it? And what happened? And what they found was that the mutant streptococci suppression only lasted for about 6 weeks. and there was no difference in the regrowth of mutant streptococci in the test group or the control group, and there was no difference in the overall checkerboard analysis of the test group or the control group at the end of the study. So basically it really had no effect on the regrowth of mutant streptococci. So, you know, it's one more study that with probiotics that I think that was disappointing. I remain open-minded on probiotics, but I think that there's a lot of research that needs to be conducted yet before we get to a point where we're using that. And again, just giving people 2 tablets, every person 2 tablets of some probiotic, I don't believe, based on a multifactorial disease with all these associated risk factors, that that's going to be a silver bullet. There aren't going to be silver bullets. One thing that I would bring up to you that I saw, and this was just published as well, was eosinophilic syndrome. And eosinophilic syndrome is an autoimmune inflammatory disease that attacks different areas of the body. It could attack the lung tissue, it could attack the liver, it could attack it randomly seems to in different individuals attack different organs or different tissues. And there was, in the span of a week's time, there were 2 patients on the East Coast in the United States who independently developed eosinophilic syndrome after taking an over-the-counter probiotic. So I think that, you know, we just have to be careful, and I think that we need to have more research, and here's certainly a negative finding, but I think that we need to all be aware of that. We need to be aware of what's going on, and if there are some, you know, downside or some downside risk, I think we need to be honest about that. This, I thought, was a very interesting study. I've been in a wellness, most of you know that I've been in a wellness coaching program now for the last 2 years, and working on getting my credentials as a wellness coach for the International Coaching Federation, and going through helping patients make behavioral change and trying to understand that whole coaching model, human behavioral change. How do we make that sustainable and successful for people? And as I continue to understand that, I'm going to continue to be able to teach that to everybody. So that's kind of where I'm headed. One of the large components, certainly, of this disease is behavioral. And, you know, I was taught how to drill and fill, and I wasn't taught the skills, communication skills, necessary to help people make sustainable lifestyle changes. So that's kind of why I've been in that program. One of the things that I came across this study in the last year in the Journal of Evidence-Based Dentistry came from June, and in this study they looked at evidence on making recommendations in dietary changes and sugar changes, and what they concluded was basically that it's more challenging and more difficult to make a behavioral change with a patient around their sugar consumption than it is around fruits and vegetables and alcohol consumption. So if you stop and think about this statement, it's harder to change somebody's sugar consumption than their alcohol consumption. Now, I'm not advocating a 12-step regimen to help them with their addiction to sugar, but I think it really brings to light the fact that sugar, we might think of sugar and that behavior as an addictive behavior, and that may be a real challenge for people. So when I went back to my usual suspects at the start of this and said one of the problems is people that consume too much sugar, if they have a dietary issue, that tends to be one of the common patterns that I see, recognize, I mean, we need to be real about the fact that this is not an easy thing to solve for people. In fact, it would be easier probably to get them off of alcohol than it would be to get them off of sugar. So I just thought that that was a really interesting study, and I wanted to kind of bring that up to you. So tonight, that's kind of in a blur, 50 minutes of research in the world of dental caries in the last 12 months, and kind of gives you the current scientific literature as of March of this year. Dental caries is a complex biofilm disease. You know, the more the research that's done and published, the more complex this model really becomes. At the end of the day, it's really about the pH, and there are so many different factors involved in this disease. I believe there is not going to be a silver bullet. So I think that we need to stop looking for a silver bullet. It's not caused by a single bacteria. You know, we can't look at it. It's not a one pathogen, one disease kind of issue, so it's not going to respond to vaccines or or the magic potion or the magic rinse or whatever. This is going to be a kind of a multifaceted approach, and it really needs to be individual specific to identifying and addressing those risk factors. And when I do that in my practice with a patient, and I'm successful with Canberra, and I identify their risk factors, and if the patient participates with me, and that's an important thing for them to change, we've been successful at doing that. The real question is, why? Why do their teeth look that way? Canberra, in my mind, answers the why question. Once you know why their teeth look that way, it gives you a much better handle on trying to figure out what to do next. And wellness coaching helps them answer their why question. Why am I here? Why do I want to change? Why is this important to me? And that's really a component of wellness coaching. But I would propose to you tonight, rather than looking at, for a silver bullet, we should really be kind of, I think, thinking in my mind of a high-capacity magazine assault rifle. We need to go all out after this disease and try and cover as many bases as possible. So I think we're instead of looking for a single silver bullet, I think we need to be looking at high-capacity magazines as kind of maybe a, well, it certainly is a timely analogy to think about at this point. So I love this quote from Albert Einstein. If we knew what we were doing, it would not be called research, would it? So I think we need to continue on our research. We continue to learn more. I'll update this again next year. This is one of my favorite topics of the year because I really love to look at the research and see how my understanding and our understanding as a profession, as this disease model continues to evolve and grow as we understand it more. The question is, are you ready? I know, Kendall, that we're ready for some questions here tonight. If you don't have a copy of this book, Bob Bowers and I wrote this book last year and published it. We have 20,000 copies in circulation now at this point in time. I'm proud to announce. I think it was 71 schools now that have different levels of implementation of the book. But what we really tried to do was break down this disease, what we know about it, what Canberra means, how do you implement Canberra, and how do you take that information and apply it to the patient in terms of trying to make good strategic therapeutic decisions with them and help them kind of create a goal for themselves. So if you don't have a copy of the book, certainly call Carry Free, and we'll send you a copy, and you can contact us. I want to thank you for being with me tonight. Caries and research and science I find exciting. I know that maybe a lot of people don't get as excited about it as I do, but certainly you can log on to carryfree.com, request a book, or you can call us. If you don't get your question answered tonight, we've got about 5 minutes or so. I'll try and hold our questions to 2 or 3 tonight, and then we'll go from there.
Yes.
So, Kendall.
Yes, I will take it. We have lots of great questions coming in. So thank you, Dr. Kutsch. Also, thanks to everyone for all of your questions. We do have quite a few coming in, so we'll get started, get through as many as we can in about the next 10 minutes. So the first question that we have is, speaking of silver, what is your position on silver nitrate?
Oh, boy.
I knew you would like that one.
Can I plead the Fifth Amendment? Silver nitrate or silver amine fluoride. This is a very interesting topic. There's a lot of ways for me to answer this question. Let me try and be as truthful as I can. The silver ion is a strong antibacterial or antimicrobial actively ion. It's great for that. So right out of the gate, the silver ion, and I think that may be why amalgam dental restorations were as successful as they were even early on. I think it may have been due to the activity of the silver ions that are certainly in the amalgam. So we know that it has a strong antimicrobial effect. Silver nitrate's been around for forever. It does not have FDA clearance to be used as, well, let's put it this way. It's an unregulated medicament, which means if you wanted to use it, you can. The FDA you can't make any claims about it, and so it's a bit of a challenge from that standpoint. There are some risks associated. On the other hand, my dear friend Steve Duffin in Salem, Oregon, if you haven't read his paper, it was in the CDA journal this last year. Steve is a phenomenal pediatric dentist. And when he first started working with silver nitrate, probably it's either 5 or 6 years ago now even, he started tracking the number of hospital cases that he had, and literally every Friday every week he was in the hospital with these children doing, the full mouth case on the severe early childhood caries kids. And he started using silver nitrate in his practice, and literally over a span of a couple of years of using silver nitrate, he went to 0 hospital cases. So his retrospective study, I think, speaks volumes about the fact that silver nitrate works certainly in children. I think it has applications there. I think it has applications for the lower socioeconomic groups within the United States. So I think if we want to talk about Medicaid, certainly silver nitrate provides an opportunity there for us that we don't have otherwise. Silver amine fluoride as well, same kind of results. Silver amine fluoride is not approved for use, and I don't think in fact, I don't think it's not that it's an unregulated medicament. I think it's not approved, but certainly it's used in other parts of the world, and they've had very good success at arresting lesions in the mouth on children. And Steve even had some great results that when he treated the mouth or those lesions in one area, it seemed to stop any new lesions from forming anywhere else in the child's mouth. So I think that certainly has some interesting potential. I'd love to see an FDA clearance so that we could make claims about it and feel safe about using it, or to have greater confidence, in terms of liability, those kind of issues in terms of using it. You certainly can use it at this point in time if you go source it and you want to do that. I would tell you that my experience with it, I've had very good experience with it on children. I've had very mixed results with it on adults. That's for my personal. I've used it, and in fact, I have it in my practice. I don't use it frequently, but I do use it in certain instances, and I think it has a broader application, certainly in different segments of our society. It does turn the teeth or the lesions black. I know that there have been a number of claims about how you can use different things to to stop that from occurring. I haven't seen that to be the case. So it tends to turn the lesions black, but an inactive, arrested black lesion is certainly better than a strongly active brown or light brown lesion in my mind. So it certainly gives us an opportunity, I think. And I think that you'll probably, hopefully, hear more from me about silver nitrate going forward. But I would refer you to Steve Duffin's paper, and it was in the CDA journal in 2012. I don't know the exact date, but we can get that information for you. So if you want to learn more about it, that was the best paper I've seen in a long time. Great question, by the way. Thank you for putting me on the spot.
Yes. So the next question is a little bit more on the side of therapy and talking to patients. So what do we do when patients say no to therapy, but we know that they need it? Are there questions that you ask that are the most successful for acceptance?
That's another really good question, and then I would kind of draw back onto my coaching skills, and I would ask them, certainly they need to be informed of what their risk for getting a new lesion in the next 12 months. If you do nothing, based on the Featherstone study, you've got an 88% chance that you're going to have a new cavity in the next 12 months. And if that's okay with you, then that's okay with me. I mean, I can't fix somebody that doesn't want to be fixed. I mean, I can't help you if you don't want to help yourself. So it opens the opportunity for us to have the conversation, and I would frame that conversation around, you need to be aware of your risk or the let's say the odds of you having a new cavity in the next 12 months if you choose to do nothing. And then I would try and refocus back to, what was your goal? And if your goal is to not have any more cavities, then probably doing nothing isn't isn't going to get you to accomplish your goal. So, as a coach, I want to hold them accountable to the point that on one hand you tell me that you don't want to have any more cavities, but on the other hand you're not willing to do anything about that to change that. And just be a mirror and reflect that back to them. You said on one hand this is what you want, but I can tell you that by continuing the path that you're on, you're not going to be able to accomplish that. So I just need to be honest with you and let you know that. Typically I have the conversation with a patient. I want to know what their focus is. I want to know what their goal is. Then we tend to move into the Ferocious Knights model, and that we've talked about it before, but then I want to know, what kind of obstacles do you see preventing you from being able to do this? Because, they may have fear. It may be a real or imagined fear, but at least try and have them communicate to you why I don't think I can do this. So let's talk about that. And then let's talk about, well, when you were trying to make a change in your life in the past, what kind of things work for you? What things have been successful that you know that you've done in the past that worked well? So let's look at what the issues are. Let's look at things that you have that are kind of opportunities or resources that you have that we know work well for you, and then let's kind of test or let's validate where we're at in terms of you making this decision to do something or to do nothing. But literally, you can't make somebody go through therapy, right? All you can do is give them the best information and just make sure that that you've explained to them that, if you choose to do nothing, this study is, well done. It's 13,000 people. It's not just a fly-by-night study. This study is very well documented and validated. You got an 88% risk of having a new cavity in the next 12 months. And if you don't want to do anything about that, if you're happy to have the cavities, I'm happy to film. If that's what you want out of this, I can do that for you. But certainly, I know it's frustrating for all of us clinicians because it's like I look at, if you just make this one change or if you do this one thing, you can probably become decay-free, but you have to want to do that. And so the best thing I can do as your coach is to just try and remind you or help you get clear on your goals. And because I think if they're clear and that's a goal, I can help them focus on that, and we can discuss whatever barriers there are. We can talk about the advantages and the resources they have, and we can help them put together a plan to make that happen. But I know that those aren't communication skills that we were taught in dental school. And that's why I'm in a coaching program. Literally, to help a lot of patients, it requires communication skills that we didn't have. But they're not complicated. They're not difficult skills. So, but I would just keep going back to the patient's stated goal, and help the patient identify that doing nothing isn't going to get them to their stated goal. Great question, by the way.
Excellent. So we will do one more question. If anybody needs to cut off the webinar, I know we're a little bit over time. You're more than welcome to do that. And again, there will be a recording of this webinar. You will be sent in a follow-up email tomorrow, so you'll be able to review it and share it if you would like. But the last question we will answer tonight is, do you see the genetic component drastically changing the way we treat the disease currently? And is altering or controlling the pH still going to be part of that treatment?
That's another great question, and I would tell you that the bottom line nature of this disease, it is a pH-specific disease. If you have prolonged periods of low pH in the mouth that are as a dysfunction of the biofilm on the teeth, that's dental caries. You're going to have net mineral loss. You have dental caries. If you don't have those prolonged periods of low pH and mineral loss, you don't have dental caries. So I think from a practical standpoint, regardless of what the risk factor is, if the nature of the disease on that metabolic output that I talked about earlier is about the pH, I think that the pH strategy is going to be valid for a very long time. Now, one of the challenges that we've got is I think that the genetic component is going to continue to make our disease model more complex. it's going to kind of confuse the picture more and more. And the greatest challenge that I see there, like it's interesting. I'm fascinated by it. I want to know more about what other genetic components there might be. The problem for us as clinicians is I can't test that. Like I can't take a swab of your teeth and tell you that you have this genetic factor or this genetic risk. So it's going to be a while probably before we're going to be able to just run a salivary sample. Now I know that David Wong and they're working on that at UCLA, but I know that we're years away from being able to actually validate any genetic testing, looking from the saliva, looking at dental caries, maybe even tens of years away from being able to do that. So in the meantime, I need to just be aware of the fact that there may be a genetic component. When you see a patient like I saw, if you read that study from Schaefer and Feingold, and you look at the 5 different or 6 different geographic patterns of decay, and you identify a geographic pattern of decay in the mouth, like they only have cavities on their mandibular incisors, I can tell you that that's probably coming from this lysyl 2 bacteriolytic enzyme that they're deficient on in their saliva. Now, how do you fix that? Well, at the end of the day, it's still a pH problem. So I'm still going to go back to pH. I'm going to use xylitol. I'm going to use, I have to stack enough things on the protective side of that balance to get the patient back to a healthy balance. So I'm going to continue to use those antimicrobial agents if it appears to be necessary or indicated for that patient based on their, like an ATP score. I'm going to use fluoride and xylitol and pH and maybe nanoparticles of hydroxyapatite for Riemann. I'm going to cluster those strategies for those patients, but I've got to have enough on that healthy side, protective side of the equation to get them back into a healthy balance. So the question is, I think we're going to learn a lot more about genetics, and it's going to appear to be a bigger and bigger role. At the end of the day, we're still going to be relying on our pH strategy because when the rubber hits the pavement, that's what's going on. That's another great question. Wow. Wish we could talk about this all night. It's my favorite topic.
Yes, we couldn't tell. Well, we had lots and lots of great questions. So thank you to everyone. Thank you, Dr. Kutsch. We weren't able to answer all of the questions coming in, so we will be replying to them throughout the week via email. Again, you will be sent a recording. If you have any questions for us at all, please don't hesitate to give us a call. If you would like a copy of the balance book and you don't have one yet, we'd be happy to send you that as well. And Dr. Kutsch, did you have anything else before we wrap up tonight?
Nope. I just want to, I tell you, I deeply appreciate everybody spending the last 60, 70 minutes with us. Anytime I talk about dental caries and I talk about scientific research, I'm always surprised if anybody shows up, and we had a few hundred people with us tonight. And so I just want to commend you all for doing that and for being here and having this interest in dental caries. And thank you for being a champion for this disease. Between us, all of us working together, we can change people's lives, and I would tell you that all of us working together are going to fundamentally change the practice of dentistry for the better. So thank you all. Have a great week.
Yes, thank you. Have a great evening.